a discovery that quietly reshapes everything you thought you knew about blood pressure management rarely arrives with fanfare. It doesn't come from a new drug, a complicated procedure, or an expensive treatment plan. Sometimes it comes from learning that something you've been doing every single day, something as simple as taking a supplement, has been done incorrectly all along. And that small error has been quietly working against you, keeping your blood pressure elevated despite your best efforts. Consider for a moment how many people faithfully take their vitamins every morning, assuming they're doing everything right. They've been told by their doctors that their vitamin D levels are low. They've been given a prescription or picked up a bottle from the pharmacy. They take it without fail, day after day, month after month, sometimes year after year. And yet their blood pressure remains stubbornly high. Their medications keep piling up. Their doctor keeps adjusting doses, adding new prescriptions, puzzled by the lack of progress. What those patients don't know, and what most doctors haven't yet learned from the most recent wave of cardiovascular research, is that there are 5 specific errors in vitamin D supplementation that can completely neutralize its blood pressure benefits. And one of those mistakes is so common, so universally practiced, that it alone can add 15 to 20 points to a person's blood pressure reading. This isn't fringe science or alternative medicine speculation. The relationship between vitamin D and blood pressure regulation is one of the most thoroughly studied topics in modern cardiovascular research. Large-scale studies tracking tens of thousands of participants over nearly a decade have confirmed what clinicians are only now beginning to understand. Vitamin D, taken correctly, can lower systolic blood pressure by 10 to 14 points. That is a reduction comparable to what many prescription medications achieve. The difference is that this costs almost nothing, produces no pharmaceutical side effects, and works with the body's own natural rhythms rather than overriding them. But the operative phrase is taken correctly, and that is precisely where most people go wrong. The first error to understand, starting from the least immediately dangerous and working toward the most critical, involves something that very few people have ever been told to consider. Vitamin D and calcium have a well-known relationship. When vitamin D levels rise, the body absorbs more calcium from food. That is generally considered beneficial, particularly for bone density in older adults. What is far less discussed is what happens to that extra calcium once it's been absorbed. Without a specific companion nutrient, calcium doesn't reliably travel to bones. Instead, it can migrate into soft tissue, and one of the most dangerous places it can accumulate is within the walls of the arteries. There was a man in his early 70s, a retired school teacher, who had been taking vitamin D supplement for 5 years after his physician discovered his levels were significantly low. His levels normalized. His diet was reasonable. His cholesterol was well managed. And yet, over those 5 years, his blood pressure crept steadily upward, and he began experiencing chest tightness during mild exertion. When imaging was performed, the results were alarming. His arteries showed extensive calcification, stiff, rigid vessel walls. His doctors were confused until a specialist asked one simple question that changed everything. Had he ever taken vitamin K2 alongside his vitamin D? He hadn't. Most people haven't, because most people have never been told about it. Vitamin K2, specifically in the form known as -7 Malawian kwaches, activates specialized proteins in the body whose primary job is to direct calcium away from soft tissue and into the skeletal system where it belongs. Without K2, the calcium that vitamin D so efficiently absorbs has no clear direction and can deposit in arterial walls, accelerating the very cardiovascular damage that vitamin D supplementation was meant to prevent. The solution is straightforward. Always pair vitamin D3 with vitamin K2 in the -7 Malawian kwaches form. A daily intake of 100 to 200 micrograms of K2 alongside vitamin D is enough to activate those calcium-directing proteins and protect arterial walls from accumulation. Many supplement formulations now combine both nutrients in a single capsule, which is ideal. If taken separately, they should be consumed at the same time. The second error involves absorption, something that sounds basic but has implications most people have never considered. Vitamin D is fat-soluble. This means it requires the presence of dietary fat in order to be absorbed through the digestive tract. A person who takes vitamin D with a glass of water or alongside a very low-fat meal may be absorbing only a fraction of what they swallow. The rest passes through without being utilized. There was a woman in her late 60s, a retired nurse, who had been prescribed vitamin D by her physician and had taken it faithfully every morning alongside a small bowl of oatmeal with black tea. After a full year on the prescribed dose, her blood levels had barely moved. Her doctor doubled the prescription. Another year passed, and while her levels had improved slightly, they were still well below target. She was bewildered. She never skipped a dose. She did everything she was told. The problem was that oatmeal and tea contained virtually no fat. Most of her vitamin D was simply not being absorbed. But newer research has added an important layer to this story. It isn't just about having fat present. The type of fat matters. Omega-3 fatty acids, the kind found in fish oil, cod liver oil, and walnuts, don't merely serve as a vehicle for vitamin D absorption. They actively work alongside vitamin D to reduce the systemic inflammation that can block vitamin D receptors at the cellular level. When this woman began taking her vitamin D alongside a tablespoon of fish oil each day, her levels jumped dramatically within 3 months, and her blood pressure, which had remained unchanged for years, began to fall measurably. For those who cannot tolerate fish oil, a small handful of walnuts or a tablespoon of flaxseed oil can serve a similar purpose. The point is that omega-3 rich fats and vitamin D are metabolic partners, not just incidental companions. The third error catches many people off guard because it involves a distinction between two forms of the same vitamin, a distinction that most physicians were never trained to emphasize. When doctors prescribe vitamin D for deficiency, the form they most commonly prescribe is vitamin D2, known scientifically as ergocalciferol. It is synthetic, it can be patented, and it has been the pharmaceutical standard for decades. But it is substantially less effective than vitamin D3, known as cholecalciferol, which is the form the human body produces naturally when skin is exposed to sunlight. Research comparing these two forms has found that D3 is roughly 5 times more effective at raising blood levels, remains active in the body for significantly longer, and binds more efficiently to vitamin D receptors throughout the body, including those in blood vessel walls and the heart. A man in his late 60s who had spent 6 months on high-dose prescription D2 saw his measured blood levels enter the normal range. Yet his blood pressure showed no meaningful change. When he transitioned to over-the-counter D3 at a comparable dose, his blood levels rose further and his blood pressure began declining within weeks. The distinction between D2 and D3 is not a technicality. It is the difference between a supplement that functions as intended and one that offers marginal benefit at best. Anyone currently taking vitamin D should check the label. Ergocalciferol means D2. Cholecalciferol means D3. The goal is always D3. The fourth error addresses dosage, and this is where even well-meaning physicians most commonly fall short. Standard prescribing guidelines for vitamin D were developed with bone health in mind, preventing rickets, reducing osteoporosis risk, maintaining skeletal integrity. The doses required for those purposes typically bring blood levels into a range of 30 to 50 nanograms per milliliter. For decades, reaching that range was considered success. But cardiovascular research has established something different. The blood pressure benefits of vitamin D, the meaningful, clinically significant reductions in systolic pressure, do not occur at those bone health levels. They require blood concentrations in the range of 50 to 70 nanograms per milliliter. And reaching that higher range requires considerably more daily supplementation than most doctors currently prescribe. 4,000 to 6,000 international units per day of D3 is what most adults require to consistently maintain levels in that cardiovascular protective range, though individual needs vary based on body weight, skin tone, sun exposure, and how efficiently a person absorbs and metabolizes the nutrient. A woman in her early 70s had taken the standard prescribed dose of 1,000 international units daily for over a year. Her levels had risen to the low 30s, acceptable by conventional standards, but insufficient for the cardiovascular benefit she was hoping to achieve. Where her daily dose was increased to 5,000 international units of D3, paired with K2 and fish oil, her levels climbed in the mid-50s within 3 months. Her blood pressure, which had sat around 154/92 for years, began declining steadily. The lesson is that normal is not the same as optimal, and the optimal range for blood pressure protection requires more aggressive, though still safe, supplementation than most people are currently taking. And now, the fifth error, the one that undoes everything else. The one that could take a person doing all 4 of the above things correctly and still strip away most of the benefit. The one that explains the largest number of cases where vitamin D appears to be ineffective for blood pressure control despite optimal blood levels and correct supplementation practices. It is simply this: taking vitamin D in the morning. This seems impossible on its face. How could the time of day matter so profoundly? The answer lies in vitamin D's relationship with the body's circadian system, the 24-hour biological clock that governs sleep, wakefulness, hormone release, nervous system activity, and cardiovascular function. Vitamin D interacts with circadian signaling pathways. When it is consumed in the morning, it reinforces the body's daytime signals. It nudges the sympathetic nervous system, the system responsible for alertness, arousal, and the fight-or-flight stress response, toward activation. That activation is normal and appropriate during the day. Heart rate rises slightly, blood vessels maintain a degree of tone, blood pressure stays in the active range. This is how the body is designed to function during waking hours. The problem emerges at night. Normally, as the body transitions into sleep, blood pressure drops by 10 to 20%. This is called nocturnal dipping, and it is one of the most important cardiovascular events that occurs in a 24-hour period. It allows the heart to rest. It reduces wear on arterial walls. It permits restorative processes that cannot occur during periods of high vascular load. People who dip normally during sleep have dramatically lower risks of heart attack, stroke, and heart failure than those who don't. When vitamin D is taken every morning, it chronically reinforces daytime sympathetic activation. The body's shift in a nighttime rest mode becomes incomplete. The nocturnal blood pressure dip is blunted or eliminated. The heart and vessels remain partially loaded throughout the night, accumulating the kind of cumulative strain that drives long-term cardiovascular damage. There was a man in his mid-70s who had done everything right. He was taking D3. His dose was appropriate. He had added K2. He was taking it with fish oil. His blood levels sat comfortably in the mid-50s, and his blood pressure, despite 3 medications, had not moved. When he enrolled in a research study comparing morning versus evening dosing and was assigned to the nighttime group, the change in his blood pressure trajectory was dramatic. Within 8 weeks of simply moving his supplement from morning to night, his readings began declining. Over the following months, his average blood pressure fell by more than 30 points. 2 of his 3 medications were eventually reduced. The only variable that changed was when he swallowed his capsule. Nighttime dosing allows vitamin D to work in alignment with the body's nocturnal biology rather than against it. It supports rather than suppresses the blood pressure dip that the sleeping body is designed to achieve. Research comparing the 2 timing approaches has found that nighttime dosing produces blood pressure reductions 4 to 5 times greater than morning dosing at identical doses. Morning dosing, across long observation periods, produced average reductions of less than 2 points. Nighttime dosing produced reductions of 10 to 14 points. Same supplement, same dose, same person. Only the clock changed. The practical protocol that emerges from all of this is straightforward. Vitamin D3, not D2, taken in a dose of 4,000 to 6,000 international units daily, paired with 100 to 200 micrograms of K2 in a -7 Malawian kwacha form, consumed alongside a tablespoon of fish oil or equivalent omega-3 source every night before bed. Blood levels should be checked after 3 months of this regimen, with the goal of landing between 50 and 70 nanograms per milliliter. Blood pressure should be monitored at home, morning and evening, and any changes in medication needs should be discussed with a physician before adjustments are made. People who have followed this complete approach, correcting all 5 errors simultaneously, have experienced blood pressure reductions that their doctors have been unable to achieve with additional pharmaceutical interventions. Not because vitamin D is a miracle, but because it is a powerful physiological tool that most people have been systematically using incorrectly. 5 small changes. 1 taken at night instead of in the morning. 1 switched from D2 to D3. 1 dose increased into the cardiovascular range. 1 tablespoon of fish oil added. 1 companion nutrient included. Together, they transform a supplement that has been doing almost nothing into one of the most effective natural tools available for blood pressure management.